Okay, so welcome everyone to the our current Australian Virtual Hip Festival. For those of you who remember, these used to be in-person events where we would travel around state by state or by country and have local people join us. We've been forced to do it this way, obviously because of COVID, but we've found that even though we don't get the, live person-to-person aspect of it, there's a lot of advantages to doing this. So, for example, as you can see, we can have hundreds of people attend a single event. So it's been quite good, and the last one was very successful, and this one looks like it's going to be very successful as well, with over 270 people registering for this event. So I'm going to start just with acknowledgement of country, and the Hip Fracture Registry acknowledge the traditional custodians of country throughout Australia and recognise their continuing connection to land, waters and community. I pay my respects to them and their cultures and to elders both past and present. Now, this is being recorded because not everybody can make it at this exact time. So it's available for you to watch again, or it's available for others to watch for the first time. And as we have with a lot of our things now, we have podcasts and a lot of links on our website to recordings that we've done. It'll be available there. And so you're consenting to this recording by sticking around. Now, this is a very important bit. If you just take a second, please. It's easy to do on your phones. You can also do it on your computers. But if you go to slido.com and then just type in event code, there's already a hashtag there. You just type in HipFest and it takes you to this meeting. You can also obviously just use the QR code there. And this is a great way of organising participant feedback in the meetings. So we can ask questions on Slido. We'll do some examples now. And you can ask questions of us on Slido. And the way that works is this is on Zoom, and most people are used to typing into chat, but we don't want you to use the chat. We've disabled the chat. We want you to use Slido. And as talks are being given, you can type in questions into Slido and post them. And the way it works is that other people can see your questions and people can vote on the questions. So instead of having, maybe 50 questions and choosing a handful of them randomly, if we have questions, they'll be ranked by how important they are, where people upvote them. And so that way we can at least answer the most important questions if we don't get to all of them. So we're going to do some example slides. So if you look at Slido now where you are and you go to polls, there's two sections. There's the Q&A where you ask questions, and there's the polls, which is what we're doing now. So if you go to polls and just click on where you're from, and then scroll down and just click send, you will see, I don't think I can show it to you because oh yeah, I can. If you just click the send at the bottom, it'll just put it in, and then you'll see a graph where you can see where people are from. And you can see at the top there, it's all a bit small, but most people are from New South Wales, then Queensland, and it's shifting around a bit as people are entering data. And you can see South Australia, New Zealand, etc. So when we ask questions during talks, you'll be able to give us your answers using that kind of thing. And so if I go to the next one, what is your profession? And that will come up now. So if you look at Slido, that will come up now. We don't have a drop-down menu for that. That means the answers might be quite mixed. It's normally better when we do these to have a thing, but this is going to give us a word cloud. Yeah, so physios, geriatricians, surgeons, nurses, clinical nurse, dietitian, and a few emojis. So yeah, you get that word cloud. All right, I'll put that down. So what I might do now, that's the last slide. I'm just going to stop sharing and just come back to you live. And what I'm going to do now is introduce the rest of the meeting. So the next session is going to be moderated by Catherine McDougall, and it gives me great pleasure to introduce Catherine because many of you know me. I've been the orthopaedic co-chair of the registry since 2012 when we started, and I'll be stepping down from that position at the end of this year. And Catherine will be taking over. And Catherine's an orthopaedic surgeon from Brisbane who's been involved in this registry for a while. And in fact, she is the Australian Orthopaedic Association official representative on the registry. But now that she's moving up to co-chair position, we're getting the AOA to advertise for another person to backfill that place on the steering committee. So it's it gives me great pleasure to hand over to Catherine now, who will congratulations on taking over. She'll take over in January. We've been going through a 6-month sort of transition period, which has been good. And please lead on with the next session. Thanks.
Thank you so much, Ian. And on behalf of all of us, thank you for your work over the last 10 years. Certainly, you've done an incredible job with Jackie and the rest of the team, and I'm really honoured to be trying to step into your very big shoes. All right, so I'm really pleased to be chairing this next session. We have 2 fabulous speakers. I'd like to introduce our first speaker. Our first speaker is Dr. Seth Tarrant, who is an orthopaedic surgeon from Newcastle. Seth completed his orthopaedic training in 2018 and did fellowships both in Switzerland and in Canada before returning to work in Newcastle. He has an extensive research profile. He's currently doing his PhD, but has researched a lot on multi-traumas, unstable pelvic injuries, and fragility fractures. As well as his role as a surgeon and a researcher, Seth has a role with the University of Newcastle as an examiner and a lecturer, and he's currently the co-chair for the New South Wales Health Agency for Clinical Innovation Hip Fracture Advisory Panel. Today, he's going to be speaking to us about the role of tranexamic acid in hip fracture. Welcome, Seth.
Thanks a lot for the gracious introduction, Catherine. I'm not sure if I've been described as fabulous before, but I'll let people make up their own minds regarding that. So I'll just attempt to share my screen. Hopefully it works. Can people see that?
Actually, we've still got the Slido screen there, Seth. So now we're good. We're good.
Excellent, excellent. Okay, so I'll try to be brief. So please discipline me if I'm going over time, Catherine. So the whole point of this talk is to sort of describe a little bit what tranexamic acid is, what do we need to know about it, and the last decades of research looking into it, from the first RCTs to the plethora of RCTs we have now, to the combination of those RCTs, and also moving on RCTs, and ultimately how can it benefit fragile patients. So for those who've done anatomy or physiology courses, I know we've probably had to learn this confusing coagulation cascade at some point in time. All we need to know from this is that it all leads to fibrin, and fibrin is the basis of what clots blood. So what is tranexamic acid? So fibrin, like most things in the body, has this sort of auto-regulation, so it can't get too much. So when you get too much fibrin, it decides to break itself down. So I read that it was the orchestrator of its own degradation, which is a nice way to put it. So when you have this clot, fibrin, when you get too much of it, plasminogen and tissue plasminogen activator bond together, then the whole thing breaks down. So there's the fibrin, this component of blood clot. What tranexamic acid does is that it blocks the lysine binding site, which is a protein on fibrin. So it blocks the ability to fibrin to break itself down. So in other words, when a clot forms, tranexamic acid stops the clot breaking down, or the confusing term hyper or fibrinolysis. So TXA was invented in the 50s. It's been used since a long time, and it's been used a lot in medicine, but it's only really had a renaissance in the last 10 years. So in the last 65 years, there's been over 5,000 articles written on tranexamic acid, but in the last 10 years, there's been 3.3 thousand. And of those specialties looking at tranexamic acid, orthopedics is by far the most interested, followed by the trauma world, and followed by some other, less important surgical specialties. What they do, I'm not entirely sure. In elective surgeries, particularly hips and knees, we use tranexamic acid all the time. And we've got to a level where we have these multi-armed RCTs looking at tranexamic acid, whether it be IV or topical, or IV and topical, or IV and topical en masse. And basically, it's superior in everything. The p-value for everything will be reduced blood loss. In trauma, however, it's a little bit confusing. The biggest trial looking at trauma, the CRASH-2 trial, with over 20,000 patients in an RCT, demonstrated that if you gave TXA to people, they had reduced death due to bleeding. Fantastic. And this sort of matched other trials in postpartum hemorrhage, such as the woman trial, which showed reduced death from bleeding. So should we give it to everybody? Well, the sub-analysis showed, and this is a confusing graph, that the further out from injury, you in fact didn't stop death, you increased it. And at this magical 180-minute mark, the odds of dying from tranexamic acid was the same as odds of dying from placebo. And beyond that, if you had TXA, you had a higher chance of dying. So what is a hip fracture patient? Is a hip fracture patient an elective hip surgery, or is it a trauma patient? Now, this is an elective hip surgical patient dancing with the surgeon at the 5-week mark. But a fractured femur, is this guy, my mate Jake, who's found on the side of a road, has to come off his motorbike. If we didn't get tranexamic acid into Jake within 3 hours, we may be killing him. So they're very different. So I'll start going a little bit of the literature. So I apologize in advance. We use statistics for support rather than elimination, like drunkards use lampposts. 2010, out of France, first RCT looking at tranexamic acid. Randomized saline. Primary outcome was transfusion. Secondary outcome was vascular events. Transfusion was reduced. Only 42% of people with TXA were transfused compared to 6% placebo. Fantastic. Vascular events are, however, 16%, and 1 in 6 patients had a death from a vascular event compared to 6% in placebo. So it was killing more patients despite the p-value. So should we use it back then? Well, I was always very hesitant to. 6 years later, fantastic. The next RCT, good journal, Bone and Joint Journal, good authors, Nikolai Foss, Henrik Palm, highly published in the hip fracture world. Denmark, good country, good data. Tranexamic acid reduces blood loss. Fantastic. But if you go through the abstract, it says the trial was stopped. Oh, maybe it was stopped because it did such a good job. Well, it did a great job of reducing blood loss. However, if we look at mortality, at the 90-day mark, 30% of patients in the tranexamic acid group were dead compared to 10% in placebo. So patients dying from this. Another RCT, this way from China, looking at outcomes, efficacy and safety. Fantastic. Is this stuff safe? Because at this point in time, I'm not sure. We look at all these p-values, blood loss, hemoglobin, day 1, day 3, transfusion rates, fantastic. However, no mention of mortality. So once all these RCTs start piling up, where is the truth? And the truth lies in these systematic reviews and meta-analyses. This was produced by Associate Professor Sadie from Sydney. A well-qualified team. We may know some of these authors. However, when we look at all these RCTs, combine them together, we notice their heterogeneity. There's different regimes for TXA. There's varied transfusion protocols, and the patient numbers aren't that great. Overall, it does make a difference requiring blood transfusion. It does reduce blood loss, and overall, there's probably no increase in complications. So great. We can probably use it. It should be safe. But are all patients the same? Well, there's chalk and cheese with some of our hip fracture patients. Some are 69 on the golf course and some are 99 in the nursing home. So we have to start being a little bit more precise with this. 2021, and this is sort of how I got ignited to give this talk, is a large email chain involving the doyens of the hip fracture community, which I'm not a part of. And all these RCTs started coming out this year. So this one was from Martin Parker, the highest published, highest cited author of hip fractures in the world from the UK. From Peterborough, excellent author. They had a large RCT. They split it up into neck of femurs and trochanteric fractures, good numbers, good randomization. For the hemiarthroplasty group, we saw reduced transfusion, reduced hemoglobin, and all the other outcomes were good with mortality. So for hemiarthroplasties, we saw reduced blood loss, which led to reduced transfusion. For the trochanteric hip fractures, or your gamma nails and your pin and plates, we didn't see any difference. So one group benefited, but the other didn't. And this to me resonated. It made sense because with a hemiarthroplasty or a total hip, the fracture itself is contained within the hip capsule. So the blood loss can't really go anywhere. And auto tamponades, you don't get a great deal of bleeding. For a trochanteric fracture, you know, the blood goes into the thigh. It's not contained by the hip capsule. So it can bleed and bleed and bleed and bleed. So when it comes to doing a minimally invasive surgery, your gamma nail, you probably don't make such a big surgical insult. So all the bleeding probably happens before surgery rather than during the surgical insult itself. So the tranexamic acid we give may not touch the sides. It makes sense. Then the same month, there was another study came out, and this was from the Bone and Joint Journal, probably a better journal than Injury, or higher cited anyway. So does that trump the other study? Looking at it, it had a fancy infographic, and it showed that blood loss was less in the inner trochs, but not the femoral neck. So this was the total opposite. But if we look at this study, the transfusion rates were through the roof. Now, 73% for control group and nearly 60% for the TXA group, which isn't a huge difference. And that's very different from the transfusion practice in Australia. And particularly in the inner trochanteric group, where the people who didn't get TXA, got saline, had an 82% transfusion rate, which is astronomical from my practice. These are the John Hunter figures since 2002. And our transfusion rate at the turn of the millennium was about 40%. That's sort of steadily crept down to the high 20s. So 82% versus 30% is chalk and cheese. So how can we accept that study or interpret that or apply it to our own practice? This was a study from China looking at trochanteric fractures themselves, so the ones that didn't benefit in the Martin Parker study, and essentially showed that hemoglobins day 1, day 2, day 3 before surgery were all less than the tranexamic acid group. So maybe we should be giving TXA to patients with trochanteric hip fractures in emergency rather than surgery, and sort of shift our paradigm a little bit. And is more TXA better? Well, this is a study from Thailand, 3 groups, it came out this year. Saline, 1 dose or 2 doses, and looking at the transfusion rates, 2 doses was far superior. However, they didn't break it up between fracture types, and whether type practice applies to Australia, I'm not sure. 3.3% compared to 43% is a huge difference, and it hasn't really been replicated by other studies. I have to give a shout out to one of the registrars, Gajan Selvakumaran, and Professor Joel Balog. They performed this little retrospective review, which is certainly not as high evidence as the other papers I presented. However, it gives a bit of insight into what we do here based upon our own sort of gut feelings, so to speak. And I suppose the most interesting thing with this retrospective review is that 80% of patients who were given TXA at the John Hunter had arthroplasty, and only 20% who didn't have TXA were arthroplasty. So we certainly have a bias towards giving patients TXA when those have arthroplasty, which is probably leading towards in the correct direction. Is it more effective though? Well, basically the only statistical group that was advantageous for giving TXA and having less transfusions was in the total hip group, which makes sense. Big surgery, repairing the femur and the acetabulum, probably didn't bleed much from the actual fracture, but a large blood loss during the surgical insult. But are all patients the same even within arthroplasty? Now, this was a group I worked with in Calgary on fellowship, and they looked at TEG, or elastographs, the thrombus, seeing how thrombus behaves. And when a patient's admitted, and excuse the busy graph, but basically what's in the pink are patients that are prone to get PEs at this magical MA of 65, and those who aren't prone in the white. And as we see in admission, maybe about 25% patients are prone of being hypercoagulable, but as we get post-surgery, it gets up and up and up and up. So there probably is a sweet spot before surgery where some people who aren't prone to clotting may benefit from TXA. As we get post-op, we should be a little bit afraid of hypercoagulating. Maybe TXA is not indicated well past surgery. Ultimately, I think the future is goal-directed resuscitation. So is looking at patients, looking at their clotting factors, and seeing or not whether they're going to clot a lot, or whether they're going to clot, nothing, or in trying to tailor TXA to the patient themselves. And that may depend on whether on anticoagulants, whether DOACs or aspirin or Plavix. So this is a busy graph, I apologize, but this is basically looking at the different phenotypes of clotting in trauma patients. So the majority of patients are in this green zone in the middle where they clot and they unclot and they clot and they unclot. Some patients are in this red line where they've got hyperfibrinolysis, so they don't clot at all, which only makes up 10% of the population. But when they have this phenotype, they have a 50% chance of dying. And the other option is where the blue line at the bottom, where in fact they stop breaking down clots, so they clot a lot, which may be where our hip fractures sit. But we don't know. This sort of information doesn't exist for hip fractures, but I think it well and truly is the future. So a lot of information there. I apologise. I'll show you my gut feeling, and anybody gets this Monty Python reference. My gut isn't that big, but it is a big gut feeling. I think whatever you do, restrictive transfusion seems to be superior. Now, some of those studies, the transfusion limits were at 10. So they transfused anybody with hemoglobin below 100. I don't think that's correct. I think we should use our blood guidelines, which is basically 80 for someone with ischemic heart disease and 70 for all other comers. I think the intracapsular fractures or arthroplasty, where the surgical insult can account for a large proportion of blood loss, I think they benefit, as supported by the Martin Parker study from injury this year. I think extracapsular may benefit from a quick post-injury dose in the emergency department. That should be assessed, by the surgeon. And the nastier the fracture pattern or the more comminuted, such as the reverse obliques, probably benefit more because we do know they bleed more. But ultimately, I think watch this space the next 5-10 years, we'll know a lot more about the particular coagulation profiles of individual replacements, be able to use technology such as Rotem and TEGS to sort of help tailor our treatment to individual patients. I'll leave it there. Feel free to shoot me any questions via my personal email or shoot some questions via Slido. I'm more than happy to chat about TEGS anytime and provide articles so people can have their own interpretations. There's a lot of studies I didn't include in this talk, so there's different ways to interpret the evidence well and truly. And of course, ways that you can use it to support yourself rather than illuminate. Thank you.
Thank you very much, Seth, for a really well-rounded presentation of what could be described as quite confusing results within the literature. I'll just remind everybody to place any questions in Slido if you have them. And while you're doing that, I'll get started. Seth, you demonstrated a graph of your current usage of TXA in Newcastle, and 80% was for elective and 20% was for your fractured NOFs. Is that correct?
Oh, no, sorry. That was 80. That was all fractured NOFs. That was hip fractures.
Oh, I apologise.
Okay. Of the 15 surgeons or 10 surgeons who arthroplasty, including total hips for trauma, 80% of their gut feelings was for intracapsular fractures, which is arthroplasty. And I don't know if they based that on evidence. I think they're just based on their own feelings. Yeah. I don't know if they've all read those RCTs, but that's just practice. That's just a snapshot of real life. Yeah.
Thank you. So I guess my question then relates to risk. So if in the most recent guidelines, most recent studies, you were able to demonstrate improvements in transfusion rate and decreased blood loss, particularly in the intracapsular fractures. But the other studies for the intratrochanteric fractures didn't really demonstrate an increase in risk. So why would you not just give it to everybody preoperatively?
Well, exactly. No, a very valid point. No, just because it doesn't, it may make an improvement. It's because it's not demonstrated by one study, but certainly there is not an increased risk profile by giving it. Doesn't appear to be so. Not that's been teased out. Yeah. Also, there are low numbers, in terms of powering for thromboembolic events that are not that common in hip fracture. Maybe these studies are underpowered for that outcome. Most of them are powered to transfusion, assuming there's a 20% transfusion decrease and assuming about 30% of the population is transfused. So they're probably not adequately powered for that outcome, which is why there's always secondary outcomes. But it probably doesn't hurt. So I take your point. You probably can give it to anybody, and it probably won't hurt them. But I think they probably have the most benefit in arthroplasty.
You also put up a really interesting slide out of Canada when you were describing assessment of somebody's hypercoagular risk, essentially, risk of clots. How specifically were they doing that? Was that, you said that was in your general trauma patients?
No, that was hip fracture as well. Sorry, is that the one that had the half white, half?
Yes. Yeah,
that was all hip fractures.
So
Yeah.
how are you determining that? How are you determining their pre-op risk? What are the factors? Because one of the common questions I get from anesthetics is, the risk of potential thromboembolic events with TXA. Does this patient still need IV TXA compared to, say, oral TXA? And that, topical TXA.
Yeah.
I'd be interested in your thoughts around, I guess, the assessment of the patient that's higher risk for a thromboembolic event, and whether you personally identify those people to be only suitable for topical versus IV, or is there no evidence?
A lot of these RCTs exclude patients with high thromboembolic risks. A lot of them exclude patients who are on anticoagulation as well. So that makes it a little bit confusing, sort of detaches it from the real world. If they've had a history of embolic event, I personally do not give it. I'm a chicken, and I will certainly head towards topical.
Okay, great. We've got a couple of questions on Slido. Seth, no, it's good. What if you're giving 2 doses? What's the timing of those doses? If the first dose within 180 minutes, when do you give the second dose, or do you just give a single dose?
Oh no, I do. I think that some of the trials do 0 and 3 hours, and I agree with that. I think it should be probably given pretty close within the surgical insult
period. Okay.
Within 3 hours of admission.
Yeah.
0, 8, and 16. But
Okay.
I think for hip fracture, maybe make the dose a little bit quicker. A lot of cardiac events happen pretty within the first couple of days. So I think if you want to try to stop bleeding, stop it as soon as possible.
Okay. Next question. Discussing tailored treatments. So tailored treatment's ideal, but in the real world, more generic protocols are the way that we're going to actually change overall management. What do you think is better in practice?
Tailored treatment compared to protocols.
Yeah.
Oh, of course, I think tailored treatment's better in practice, but is resource reliant. It is time dependent. You need people doing these. It's expensive to have a TEG machine lying around in the resus bay. So I think that for maybe a subset of the population that have a previous thromboembolic disease, that have a high risk injury pattern, such as a reverse oblique, if they're anticoagulated, then maybe tailored treatment can be used for a subset of the population. But for the run-of-the-mill sort of 83-year-old female, broken neck of femur, gets around on a stick, still talks to a family and goes to the bowling club, I think you probably have protocols for the majority of patients. I think it's probably safe to give for hemis, and probably safe to give for trochanteric fractures for most comers.
Thank you. A question about your studies and mobilisation. Are you aware if any of your studies looked at secondary outcomes related to post-op hypotension and mobilisation and TXA use?
No, I'm not aware of. I've read a lot of stuff on TXA in the last couple of weeks, but I don't think. I'm not sure about post-op hypertension. That hasn't stood out. But in terms of mobilisation, whether it be a up and go score or a cumulative ambulatory score, I don't think anybody looked at some sort of objective marker of mobilisation.
Okay, great. Thank you. And probably last question, relates a little bit to what we were speaking about earlier. Are you aware for hip fracture patients, is there a recommendation for IV versus topical TXA? Obviously in elective arthroplasty patients, it's pretty much demonstrated you can do any.
Yes.
Is there a particular recommendation for hip fracture patients?
No, I don't have any particular recommendations. There was a Chinese study looking at topical TXA RCT that did show benefit, so it has been proved. I do like using it, and I did a periprosthetic last night. I put 2 grams of TXA, in at the end, just to cross my fingers and hope for the best, plus IV TXA that they'd already had. So I'm a fan of topical TXA. In terms of specific protocols, I think it can be added, with gay abandon. I don't think it's gonna hurt. Mm-hmm. So I would recommend surgeons do it.
Great. Well, thank you very much, Seth. That's a great presentation, a really good discussion around the literature. Thanks very much for joining us today.
Yeah, thank you very much.